So thank you, Dominic, for a warm introduction. So this talk is not going to be that data heavy. It's going to be more, I'm going to try and argue two main points. One would be that the psychotherapy model we use is, well, we know it's pretty safe, but we don't really know what sort of models or what sort of tweaks we can actually do to it. And I would also argue that it's somewhat limited and constrained, and there could be unused potentials there. So, I mean, all the psychiatrists have been very, obedient when it comes to addressing conflicts of interest, but it's kind of obvious. I work for Awakn, which is a ketamine clinic. I also do adherence rating for MAPS, so they give me a little bit of money. But I don't think this is really relevant to this talk. Okay. So one of my main points is going to be the unused potentials of the psychedelic session day. The other point I would like to argue, and I think most people agree with this, we heard a little bit about it during the panel discussion related to implementation. That is the need for a broad variety of psychotherapy models to be integrated with a psychedelic therapy model as we do it today. So, when you look at psychedelics used as treatments, there are primarily three different ways to do this. Willy Pedersen addressed some of it on the first day when he talked about the history, especially in Norway. But I'm going to tap briefly into it for those who wasn't here or has forgotten it. So, one way to use psychedelics in treatments is just to consider it as a regular pharmacological treatment. Nobody does this anymore for good reason. It didn't work and it was highly dangerous. However, the Danes kind of fucked up during the 1960s, 1970s, especially if you look at the research being done at Fredriksberg Hospital. They delivered this, and they had this biological model that the psilocybin and the LSD would do something to the brain, and this is the main mechanism of action. So they just said, hey, if you just survive this stress-induced state, you will feel better. And this also had major implications for how they treated their clients by providing them a safe room, but a locked room with no therapist. And they also even restrained some clients down on a bed. And this is, of course, a really, really bad setting, as we now know. So nobody does this anymore. And when you look at what happened in Denmark, I'm not sure, but to my knowledge, they are the only country which actually, the state came in 1985 and they implemented a law. It's called the Lsd Damage Law, which any client who received psychedelic therapy in Denmark during the first wave of research would get the compensation if they felt that they would have been damaged. And over 200 clients applied for this and got compensation due to damage being done in psychedelic therapy. But when you look into those numbers and you look at who were those clients and which research center were they from, the majority came from the Fredriksberg Hospital, where they had this pharmacological approach. Nobody came from, for instance, Montebello-klinikken, and they delivered a psycholytic approach. That is a psychoanalytic, psychodynamic treatment framework in which psychedelics were used as a part of the treatment process. So this takes us to the other tradition of psychedelic therapy, which is psycholytic therapy. This has been done greatly, I believe, mostly in Europe. It is usually credited to the German psychiatrist Hans Karl Leuner, but also many others. And it was practiced in Norway and Modum Bad. And this is the idea that the psychedelics really complement the psychotherapy. And the psychotherapy itself is maybe the most major part of the whole treatment, and that the psychedelics themselves can really help open up the mind, but also make the unconscious more conscious. So it's very heavy in the Freudian old conflict pathology thinking. In the US, this was also done, but I think primarily, I mean, it's an artificial split that I'm making, but I think we'd say Europe had more psycholytic therapy during the first day of research. And in the US they did, and in Canada, they developed a psychedelic therapy. It's usually credited to Humphrey Osmond and Hoffer at the Weyburn Hospital in Canada, where they did research in alcoholic clients. This has been addressed several times during the conference, so I kind of regret being sort of last on the program because my slides are getting stripped down for every speaker. But I think most of you know that the psychedelic therapy model, it's not that heavy in the psychotherapy aspect, but the idea is to facilitate a really strong peak mystical experience, and that is through this experience that the client will get better. This was built on a hypothesis that the clients who came in for alcohol addiction, those who went into this state of delirium, which is a very horrible bad trip experience, the researchers had this idea that these clients had better outcomes in the long run. So they thought, hey, maybe we can do it in a safe way with psychedelics instead. And the results were opposite. They realized that those who have a good, positive experience during the psychedelic trip get a good treatment outcome. So these are the three main ideas that has been historically applied for the use of psychedelics. And it sort of looks like this. This is for the psychedelic therapy treatment. We have preparation. I mean, all of you have heard of this already, where you prepare participants for the drug effects. You set treatment goals, but it's also very important to build a good and safe relationship between the client and the therapist, so that this can actually work as a support during the part of therapy where they actually get the psychedelic. So that is part 2, this yellow circle here called psychedelic support, where the psychological support is provided by at least 2 therapists, and it's very non-directive, and a client is laying down on a sofa or on a bed, and they get music, and it's a very inward process. This is idea of the inner healing intelligence and so forth. And there's this idea that the therapist is more there almost like a midwife, or almost like someone facilitating a birth or facilitating a very positive experience. And then there is the integration part, where you talk with the therapist after the trip, and yeah, you get the idea. Usually this model is, preparation is 2 to 4 hours, either done in 1 or several sessions. The psychedelic support is 6 to 8 hours, mostly with music, and integration is usually 2 to 6 hours. And so to actually look when you look into psychedelic psychotherapy today, you're limited to looking at the research clinical trials. So in a paper I wrote together with the team in London Imperial, we just assessed the clinical efficacy of these trials, but we also tapped into the psychotherapy models. And I wanted to look at how do they actually do it, because this psychedelic therapy is more of an idea, but do all the trials actually adhere to it? So when it comes to the aspect of preparation and integrations, all these 13 clinical trials from the year 2000 until today, they provided preparation and support during the psychedelic session. One trial even delivered cognitive behavioral therapy and motivational interviewing, or motivational enhancement therapy. That is the Bogenschutz trial for alcohol use disorder. And one trial delivered CBT only. When it comes to the rest of these 11 trials, they delivered some sort of supportive psychotherapy or eclectic psychotherapy. One trial actually provided group therapy, but it was not during the psychedelic effects. It was in the preparation and the integration phase. All but 2 trials provided integration sessions following the psychedelic dosing day. So you can see there is somewhat variations. Some researchers tried to do more of a pharmacological trial to minimize the psychotherapy aspects, while others really went heavy on, especially for the alcohol and nicotine addiction trial, where they had in total 40 hours psychotherapy. So if you zoom in on look at specifically on the psychedelic session day, you could somewhat divide it, at least we decided to divide it into 5 core factors. There is, in the majority of these trials, that is in 11 of these 13 trials, they adhere to these 5 factors. So it's always an individual session. It's usually 6 hours standardized music playlist. However, one trial decided not to use any music at all. There's always a therapist present during the psychedelic effects, and the client is invited to look inward, and they're giving an eye mask to provide less sensory input from the outside environment, and they are lying down or sitting in a reclined chair. And part number 2, all of these therapists are instructed to deliver non-directive supportive psychotherapy during the psychedelic effects. And this is a very, mainstream way to deliver psychotherapy, but we know very little about how any of these factors actually influence the outcome, or in what way these factors could be adjusted to really fit the individual. As there was spoken about a little bit during the panel, when it comes to implementation, you also have to think about, as Ingmar asked, you have to find out which therapy works for what clients. And then I think for the future it would be important also to look into this part of the psychedelic therapy model. Maybe we need to adjust something here, because this is overall a very closed down therapy model, considering it's a very open research, people doing this research. And I think there could be some benefit to actually trying to tweak or look at these individual factors for the future. So when you look at the history here, it's really important to look at the psychedelic therapy in terms of it's a music therapy. We talk about it, some even use the term psilocybin with assisted support from the Compass company, and some call it psychedelic-assisted psychotherapy, but it would be fair to call it psychedelic-assisted music psychotherapy. When you look at the history from back in the 1960s, Bonnie Hill and Walter Pahnke was the ones who developed the psychedelic research in Maryland Psychiatric Research Center. Later on, Bonnie Hill split off from the psychedelic research group, and she created her own model called guided imagery and music. So this started out with actually live music, where she played violin for the patients while they were in the psychedelic session day, and she could adjust the music and sort of fit it directly to the client feedback. And this idea of introspection and focused internal emotional processing, staying with and opening up for the unfolding experience, is also very much, from my understanding, related to Bonnie Hill and this way of their tradition at the Maryland Psychiatric Center. And they also had a focus on creating a psychedelic peak experience. So this is a little bit about the history and why this is as it is today. And I will also argue that the Bonnie Hill method of guided imagery and music is a very effective depression treatment modality. As we have seen when you compare the placebo to the psilocybin trials, you see the effect, and I would argue that is due to the music psychotherapy that it actually shows. So this is a safe platform. It's a great way for some clients to work on accepting and exposing themselves to their internal emotions, which they might avoid or have trouble accepting. So it is a great model, but I think it could hinder some clients in working on what they need to work on. So if you look briefly down at the history, during the 1960s, 1970s, actually several other different models were used. Some were tried out, they were more open and in line with existential psychotherapy. Some actually provided group psychotherapy with no music present, but different props, different arts or paintings they could interact with, or they can interact with each other. So these models have also been tested during the 1960s, but we know very little about how effective they are. But I would argue they're pretty safe. I mean, as Otto had in this lecture just before me, there are obvious factors which needs to be done. It needs to be a supportive environment, and it needs to be a preparation, but maybe it's possible to actually open it up a little bit more. We know from research from the lab of Franz Wollenweider that the activation of serotonin 5A receptor in his study by LSD actually modulates the process of meaning attribution to external stimuli. They did this fantastic article. It's called LSD, the Fabric of Meaning. It's a great title. But that article is also very important from my perspective when it comes to developing or thinking about the psychedelic treatment model. Because they saw that when you activate serotonin 2A, people start to attribute more meaning to previously meaningless songs. So they would play the playlist with songs that, is a boring song, please play the next one. Then they were given LSD, and all of a sudden this song was about their relationship to their child or something like that. So it's a very important way to sort of tweak this meaning-making process, which is obviously needed in a lot of clients with depression, where meaninglessness or hopelessness is the main symptom. So how could you tweak this? Would it be helpful to open up if you took away the eye mask and you could actually interact with the environment around you? Maybe that meaning-making attribution process could play out in many different ways, which many other clients might also need. I would argue, looking at arguments for if this would be beneficial, you can't look at the research trials because we've all adhered to this, typical closed-down model, where with the inward focus. So I would like to present a little case report of a client that contacted me. And she had a little different psychedelic session day because she didn't do psychedelics in a research trial. She did it recreationally. This is a client that contacted me due to using psychedelics and wanting to talk with a therapist about their psychedelic use and reflect on it. And, this is the usual harm reduction or integration psychotherapy. But, our talk therapy didn't really seem to help much. We focused a little bit psychodynamically, and, this didn't really help her social anxiety. But after a while, we both agreed that, her way of using psychedelics wasn't really beneficial. And I started thinking, hey, maybe you should just tap her down or just stop doing psychedelics for a year and see how that goes. And she tapered down and stopped using it, but 3 months into the therapy, she told me she had a trip, and I was sort of disappointed, like, didn't you quit psychedelics? But she had a trip, and a very important trip for her, together with 3 close friends. They had taken mushrooms at her friend's house during the summer, and some hours in after the peak, they were sitting on the porch and just, relaxing and enjoying the sunset. Some hours in, she felt a bit uneasy, and she entertained the idea that, hey, maybe I should go read a book or maybe listen to some music. But then she decided, hey, I might as well just stay here with my friends and just enjoy the sunset, or I can just sit down here and read a book. I don't need to go away from them. So she sat there on her porch with the 3 of her friends, and she started reading in her book. But then after a while, she started hearing her friends criticizing her. They were talking behind her back, making fun of her. And being on a psychedelic, she started freaking out. This was a really bad trip coming on for her. And she didn't know what to do. She was almost like hiding behind a book, which is sometimes for individuals with social anxiety a way to control or try to stay in a very stressful situation. But then she peeked over her book and looked at her friends, which were actually sitting 2 meters in front of her. And when she looked at them, she saw that, their mouths weren't even moving, but she could still hear their voices criticizing her, talking about her. And she looked at their body language, and they weren't even moving either. When she looked at them, she actually saw that, hey, they're just sitting down, enjoying the sunset, being very mindful. But in her head, she could still hear these voices criticizing her, talking about her back. And then all of a sudden she heard another voice which said, this is interesting, which was her own voice. And all the voices stopped. So, this is only a little case report, but I think it highlights very important the importance of interpersonal experiences which can occur if we were to open up the psychedelic model a little bit more. And maybe there could even be a good case there for working with social anxiety. And of course, in our therapy, this became a very important event to explore, and for her also very easy to integrate, because this was actually going on in her real lived life. This wasn't something imaginary in her inward process or in her fantasy. This was actually her inner dynamics of projecting her critical self onto others, being live and being very visible or very hearable for her. So she tells me that she's better with the social anxiety today. It's not gone, but it's better, and she hasn't taken psychedelics since. I was kind of happy with that she actually stopped. So looking at these relational factors, let's say if you were to open up the psychedelic model to also include interaction with other people. There is some evidence for this. I mean, this little case I had is not a good evidence for anything, but at least there's an emergent phenomenon there. And if you look at the qualitative interviews with all the clients at London Imperial, you hear many of them, even in a trial where it's very inward focus, they experience increased connectedness to self, which I think is very in line with the model, since you're actually working on inward connection with yourself, but also more connection to others and to the environment after psilocybin. If you look at research from more recreational users, you could look at one study by Kettner and their colleagues. They wanted to measure whether acute relational experiences of perceived togetherness and shared humanity predicted later treatment outcomes in people participating in psychedelic retreats and ceremonies. And they did in fact found this, that relational spontaneous experiences predicts later well-being and increased sense of social connectedness and relational tolerance. Also one very important trial from London Imperial done by Roberta Murphy and the rest of the research group there shows that when it's looking at therapeutic mechanisms, which the field has been looking at the peak psychedelic experience as the main mechanism, at least the main psychological mechanism, she was actually the first looking at the therapeutic alliance, where they found that the degree of therapeutic alliance before psilocybin predicts a greater degree of mystical experience and emotional breakthrough later on. So to be able to not only just open up the psychedelic session day, but I think also open up the whole psychotherapeutic model and addressing more relational aspects would be very important. I'm a little bit short on time, but I'm very grateful that Henrik talked so much about ACT, and I could just skip this slide, but it's a good fit, and I really agree. It's a good fit because ACT, due to the psychotherapy, you want to induce changes in psychological flexibility, and it's a good match between the perceived or the underlying drug-induced changes in the default mode network being more flexible. And many clients can be treated with this approach, and also would argue many can't, especially clients with more attachment trauma or more relational experiences, which has, due to their upbringing, become a part of their internalized way of relating to themselves and others, would need a higher degree of the here and now focus during the psychedelic therapy, especially before they would get a psychedelic. So this builds the case, at least in my opinion, for also integrating the relational psychotherapy models, such as interpersonal psychodynamic psychotherapy or mentalization-based psychotherapy, where the main focus of many of these therapies are the focus on attachment and the focus on connection. And usually the focus is to explore together in the here and now with a therapist how you lose or how you obtain the connection together and how this feels, and to help the client see how these automatical patterns of attachment dynamics interfere with their core need and wish for a safe and stable relationship in their lives. I would argue this is a great approach to work with for clients who primarily are depressed due to relational problems. My main points here is mainly that modern psychodynamic relational psychotherapy may have substantial contribution to the future development of the psychedelic treatment model. And looking at the integration and preparation phase, I would say that the psychodynamic therapy has a lot of theory, which is very applicable to therapeutic practice when it comes to assessing the personality. That is the affect integration, the attachment style, the defense mechanism, and the ability to reflect or mentalize. And they have many good ways of how to match these patient characteristics with the actual appropriate focus and goal of therapy, which in my opinion, maybe the psychedelic therapy today is a little bit loose in how to define the goals. And psychological effects from psychedelics, such as increased connection to self, others, and social connectedness, fit also very well with the treatment focus of relational therapy. So, I mean, if you were to do a future trial, it would be quite easy, actually, to make a good rationale for why relational psychotherapy and psychedelics is a good fit, just as it is with ACT and brain imaging. But also, we need a variety of psychotherapy approaches, And the individualized psychedelic therapy session day, focus on introspection and music-driven psychedelic session day, may reduce the chance of other important experiences, which might also be just as important as this mystical experience, which there is some evidence for working. And just to address that, the idea about the psychedelic experience predicting outcome, there is some evidence, but for all these 13 trials, only 8 of them found a relationship. And of those 8 trials, many of them applied as much as 4 different measures to look at the psychedelic mystical experience. So, you know, you should expect to find something when you apply that many measures. So it might not be as strong of an evidence base for this argument as we think it is. It might be a little assumption we all have. But that we will know for the future. So I think also meaning attribution process into other stimuli than music could be very beneficial for many clients with many other psychiatric disorders. And also it could help with more spontaneous corrective relational experiences, just as I tried to exemplify with my case. Yeah, I think that's my main points. Thank you.